Good afternoon, ladies and gentlemen. Welcome. Welcome to this session on Transatlantic Lessons for Global Health from DC to Berlin. My name is Adnan Haider. I currently serve as the International President of the World Health Summit for this year, 2023. My day job is to be a Research Dean at the George Washington University School of Public Health, and I'm greatly honored to be your host and the chair of this session for today. Folks, we understand that this is a very complicated and complex world, particularly right now. But in this complexity, it is the responsibility of those of us in global health to actually look and find solutions that can actually work, that can actually be implemented, and that hopefully will actually impact real lives in the real world. As part of this collaborative spirit, we have to work together, even if geographical distances separate us. So today's session is about whether the two sides of the Atlantic, the North American continent, from Canada right down to Argentina, the European continent, and allied continents can work together. It's about partnership. It's about collaboration, something that I think we need to focus more and more, increasingly, in this complex world. And I'm so delighted that we have an amazing panel. We have representatives from intergovernmental organizations, from governments, from the academic sector, and from the private sector. So truly an intersectoral representation of leaders who are highly experienced in this field. And I'm honored that they will have an opportunity to reflect on this topic today. Now, if you want to know more about them, I suggest you go online, because I'm not going to spend minutes and minutes spending on their biodata and their CVs. They are all experienced, all eminent, and highly resourceful. And I wish I had the time to expound more on that, but I won't, with due respect to my dear colleagues on the panel here. What I'll request each one of them to do is to spend a few minutes giving their early thoughts on this notion of transatlantic cooperation. What types of global health issues require this type of partnerships? What are some of the examples of this type of partnership that have been successful or that haven't worked, that we can use as a learning case study? And how can partners on both sides of the Atlantic work together? What are the rules of engagement? What are the rules of partnership that are going to be critical for us going forward? They are free to choose either one or all of those issues in their reflection, and I'm sure that they've thought about this prior to coming here. So let me begin by welcoming first Dr. Jarbas Barbosa. We are honored to have you, Dr. Barbosa. He is the Regional Director of the Pan American Health Organization, which is the regional Latin American organization of the World Health Organization. Dr. Barbosa, of course, has been minister and all sorts of things in health that we can think about, with tremendous expertise in health policy and systems. I'd love to hear your reflections, sir, on transatlantic partnership.
Thank you. Thank you and good afternoon. I want to thank you for this introduction. I want also to thank George Washington University, the M8 Alliance, for organizing this panel. The region of the Americas spans two continents with enormous geographical and ecological diversity. It's a region of economic and educational prowess, scientific and technological capacity, and rich cultures and traditions. But being unique does not mean we are free from influence. It's important to acknowledge that we retain strong historic, economic, and cultural ties that bind us to our European partner countries. With these ties come a multitude of benefits, but also challenges. Our shared and complex history of colonialism has led to the persistent subjugation of basic human rights. Countries in the Americas are still struggling with inequalities in access to health, education, and social protection, while facing significant demographic changes, including an aging population that needs long-term social and health care. These obstacles present an enormous challenge for the sustainability of our health systems. But one of the great benefits of this transatlantic relationship is that nobody has to face these health concerns alone. In fact, we share them, and together can openly discuss and identify joint priorities for actions across Europe and the Americas. Looking back at our response to COVID-19 on both sides of the ocean, it is evident that we fell short despite the resources that were available to us. Our health systems were ill-prepared, trust in science waned, and our capacity to respond was limited by restricted and ultimately untimely access to basic life-saving supplies, from personal protective equipment to diagnosis to medicines to vaccines. When I took on my role as director of the Pan American Health Organization earlier this year, it was important for me to engage on these issues with my region and in Europe. I reached out to my colleagues and dear friends, Hans Klug and Lois Pace, to discuss our perspectives and determine how we could grow together. As we embarked on this transatlantic dialogue, it became evident that we needed to collectively establish a collaborative approach to strengthen health security, health equity, and the global health architecture that we share. So on April 14, 2023, the United States Department of Health and Human Services, WHO Regional Office for Europe, and PAHO is also WHO Regional Office for the Americas, but we are a double organization. So we signed a collaboration framework agreement that we believe will provide three key strategic benefits for both the Americas and Europe. First, this framework offers a new platform for addressing a common agenda. This presents a huge opportunity to work together on issues of mutual interest, from healthy workforce mobilization and climate change to antimicrobial resistance and the health of migrants and refugees. We can now establish collaborative transatlantic networks for pandemic response and mobilize the tremendous capacity of Europe and the Americas to promote global health security. In short, this collaboration framework offers us a space to build from our shared experience and find shared solutions to shared challenges. Secondly, this framework seeks to optimize Europe's engagement in the health and development agenda of the Americas. PAHO is fully engaged with the EU-LAC strategic partnership and is working with our colleagues in the European Union and WHO through key initiatives such as the Universal Health Coverage Partnership to strengthen the control and prevention of non-communicable diseases, promote the elimination of communicable diseases, and address gaps in maternal and child health in more than 17 countries in the Americas. We have also recently signed a cooperation agreement with the European Commission to strengthen manufacturing capacity for medicines, vaccines, and health technologies in Latin America and the Caribbean. This agreement is key to strengthening transatlantic cooperation in science and technology, technology transfer, and regulatory system strengthening in the Americas. These efforts complement the work and support with our other key partners in this area, especially with the United States of America and Canada, and builds on our other areas of work with the Commission, including in antimicrobial resistance. Whether it is an area of digital transformation, antimicrobial resistance, or strengthening our pharmaceutical sectors, we look to Europe for continuous support and to share its experience and knowledge with the Americas. And finally, at the core of this agreement is that it's not one-sided. The Americas have much to offer to Europe as well. PAHO and the Americas have over 40 years of experience in pooled procured mechanisms of vaccines and medicines. This is a unique experience among all the 6 regions of WHO, and more than 20 years in developing and supporting the development of regional production capacity in the region. The impact of our regional revolving funds is evident in the region's elimination of several vaccine-preventable diseases and the ongoing elimination initiative of HIV/AIDS, TB, hepatitis C, malaria, and other 27 diseases. PAHO's virtual campus for public health, an educational platform designed to improve technical cooperation with our member states, reaches more than 2.5 million health workers in the Americas, building capacity in COVID-19 prevention and management, expanding access to non-communicable disease care and treatment through primary health care, strengthening regulatory capacities in countries, and many other relevant topics. Beyond this, our countries have in-depth experience in health and development, and PAHO is already facilitating their work to share this knowledge outside the region. For instance, Chile and Colombia are engaged with European countries in health sector reforms, while Guyana and Jamaica collaborate on addressing health workforce migration and mobility. This is far from the limit of our collaboration across the Atlantic, and I know that as our regions continue to engage in forums such as the World Health Summit, both here in Berlin and in Washington, D.C., earlier this year, we can further benefit the health and well-being of all peoples in the Americas and Europe. PAHO is committed to building bridges across the Atlantic and to bring the Americas and Europe closer together, and maybe this also can be an inspiration to build bridges to our brothers and sisters in Africa that are at the other side of the Atlantic too, exactly. And they probably will benefit a lot if we can have this collaboration in the near future with a good dialogue with them. So I want to express my thanks to Lois, to Euro. Hans is not here, but is well represented here and is with us in spirit because he is very enthusiastic about this initiative. Our key partners in this endeavor as we lay down the foundation of this new partnership that I hope will be beneficial for all peoples across our continent. And thank you, Adnan, again for bringing us together today to have this very good conversation. Thank you.
Thank you very much, Dr. Barbosa. Your original point about a post-colonial world and how colonialism affects this interaction, we'll come back to that. Your reminder of the existing inequities and how the cooperation is working, and congratulations on that wonderful agreement that you've signed. And I really liked your last point, that one should not assume that lessons are going from Europe to America, but they are going from South America and Latin America to Europe as well. And we'll come back to that point as well. Thank you. Yeah. I'm honored next to invite Ms. Lois Pace, the Assistant Secretary for Global Affairs in the Department of Health and Human Services in the US government, but more importantly, a tremendous public health professional, a colleague, and I'm really honored, Lois, that you're here today with us for your opening reflections.
Oh, thank you, Adnan. Appreciate that. I hope you don't mind. I'll do those from the table if that's okay. Great, especially because Jarvis, said many things that I would have, and so it allows me to be even more brief. But I do want to obviously thank you, Adnan, for having us here today, and thank my dear colleague, Dr. Jarvis, for his leadership in PAHO. It's just been very exciting to have you in this role. It still feels fairly new, at least in the first year, so we can keep congratulating you. But also just thank you for coming together along with Dr. Kluge and in Euro and showing us how we can move forward on this very, I think, sort of model transatlantic partnership. Our staff, I want to also acknowledge, work mightily to keep us honest and to ensure that it's not just an agreement in writing, but something that we can sort of show and tell as time goes on. And so I know they're working mightily on many of the priorities that Jarvis mentioned today. And in addition to what he offered as well, I guess I just want to step back and really answer this question, why we even bother, right? And there are plenty of people who might say, although fewer maybe these days, that America has it all figured out, right? That we have all that we need, that we have the resources, the expertise, whatever is required to solve our own problems. We, as public health professionals based in the US, know that that's not true, and it's one of the reasons why we've worked over decades and decades to partner with people from around the world, not just in Europe, but in other places across the Atlantic and certainly throughout the Americas. And so I'd like to think that these types of agreements or arrangements are a reflection of that history and that belief that we can't do any of this alone. And in fact, it's, I think there's another purpose of these, which is there's so much that happens at a global level. There's so many dialogues or discussions or agreements and commitments, which is great. I spend a lot of my time in chairs raising flags, right? But what do we do after we leave those rooms? And I think these agreements really offer a sort of framework for us to execute or otherwise implement those lofty commitments and goals. So in other words, as we walk out of, WHO or World Health Assembly settings, agreeing to drive or advance equity with regards to medical countermeasures, we can then have an arrangement across the U.S., WHO Euro, WHO PAHO, and say, okay, how do we partner on something like medical manufacturing, right? Similarly, I think if we just think about the lessons from COVID alone, I think that's really what drove us and our teams to think critically about how we could accelerate progress and even sort of push the conversation at a global level. I've already mentioned medical manufacturing as an example. I think another high priority that I know Hans has touched on very often has been this sort of pandemic of mis and disinformation. And as it affects how we even are able to utilize those very innovations. What's the point of having all this progress in health technology if there's no uptake, right? And so we, again, have come together to try and solve those types of problems, again, sort of in the wake of a COVID. And I think something else that Jarvis mentioned, which is really quite important, is how we now zoom out and think of the One Health agenda broadly, whether we come at it from the climate perspective or think about it in terms of AMR, which is going to be more and more in the health dialogue going into next year. There's so many issues that fall into that sort of pillar of work and that need to be resolved at the intersection of environmental, human, and animal health. And so again, why should we sort of sit alone in our own offices and labs or wherever trying to solve those problems alone when we absolutely do have each other? So very pleased with the trilateral arrangement of partnership that we did launch in April. On the heels of that, Secretary Becerra also was able to launch with Commissioner Kyriakides of the European Commission this new EU-US Health Task Force. And it has a similar goal, as you can imagine. But they really came together and asked some of the same questions about how we could jointly advance health innovations and investments in R&D in particular, especially for issues related to global health security. But not only think of security, also importantly consider global health equity and how we could work jointly on those priorities, especially considering members of the EU where they have stood historically on access to health and, importantly, issues of sexual reproductive health and rights. And so beyond the sort of global health security space that we've all been obsessed with the past few years, we also are partnering on very core systems and access issues as part of that arrangement as well. I think the last reflection I have on, again, not just the value of these types of partnerships, but how we implement them is maybe getting to Jarvis's last point as well. You know, we have these other forums where some of these same actors come together, right? Whether we're talking about the G7 or even the G20, especially now that the G20 has been brought in to include the AU. There's a lot of promise there, and you know, we don't need to sign an agreement every time we want to do something together. We certainly can just come together in India or in Brazil or elsewhere and say, okay, we know we share these problems, and we know we don't represent the world, and yet, you know, what we do here can absolutely influence or inform what we do as a global community. So, what is our responsibility to model what's best and what's right for each of us, or frankly, work in reverse, like Adnan was saying, and consider what the world is demanding of us, right? We do wield a lot of power in those spaces, and what's our responsibility or obligation to use that power responsibly, right? And to frankly use it equitably in a way that I know we'll be talking about later today too. So that excites me as well, the ways that those tables are being widened and more seats are being brought in so that we can have those truly important and increasingly inclusive conversations, again, for the benefit of everyone that we aim to serve. And with that, that's my closing.
Thank you very much, Ms. Pace. I'm particularly excited that you're raising the question of why. And it's important, particularly from your vantage point. And this notion of addressing global health inequities, inclusion, something that you've mentioned about expanding the space is incredibly important. And congratulations on the EU-US Health Task Force as well. We'll hopefully come back to some of these points. I'm now delighted that representing the European Regional Office of the World Health Organization is Dr. Gundu Weiler. Dr. Weiler is the Director of Countries, Partnerships and Support at the WHO Regional Office, and I know comes with the full backing of Dr. Hans Kluge. So we would be very pleased to hear both your personal perspective and also your regional perspective, Dr. Weiler.
Thank you, Professor Harder. And yes, great pleasure to be here. And indeed, I bring greetings of our regional director, Dr. Hans Kluge, who, as you rightly said, is very enthusiastic about the Transatlantic Partnership and was one of the driving forces behind signing the trilateral agreement that you both referred to, that was signed April this year with Dr. Barbosa and Lois Pace for the HSS and for the PAHO organization. So you might know that the WHO European region is covering 53 countries. So these are the European countries, but also includes countries in Central Asia. And we do consider ourselves as the platform for a pan-European approach to health. And in this, we are indeed working very closely with the European Union, covering the 27 member states, and who are equally committed, as you've just said, Lois, to the Transatlantic Partnership, and who've got a dedicated section in the EU Global Health Strategy on this, and now also the Transatlantic Health Task Force. Now, if you allow me, I would like just to add three perspectives to what was said so far on how we think transatlantic collaboration can become even a stronger lever for collaboration on health development for the benefit of certain countries, for addressing the emerging domestic health agendas that we see on both sides of the Atlantic, and also for shaping a new global health policy architecture. So let me start with the first one, and acknowledging that, of course, there's a very long-standing collaboration, very intensive collaboration, and a lot of support that is being received, and particularly by the United States in countries in Europe and Central Asia. And support that is probably most well established in a more unidirectional initiative, I would say, in the sense of a more traditional development collaboration, where certain countries are benefiting from support to develop specific aspects of the health system or to respond to specific crises. So CDC, for example, a huge program of collaboration for many years, for instance, on the issue of immunization, strengthening of laboratory capacity, USAID being very active in collaboration with us in many countries, most recently in the COVID response, but also to develop specific aspects of the health system. So just to mention a figure, in 22-23 there were $133 million that flew through WHO Europe to the benefit of specific countries. But we also have it the other way around, by the way. There are many European countries who are supporting countries in the Americas through PAHO in the other direction. Now, in this, with regard to development collaboration, we do believe there's certainly a potential to be more strategic about this and to line better our support. And one of the striking examples is our collaboration on supporting Ukraine recently, where the US and WHO do not work only alongside each other, but we've also increasingly joined up strategically to advocate for putting health at the core of recovery in Ukraine in the medium and longer term perspective. And doing this, for instance, in these recovery conferences where we acted together over the last couple of years. The second point I want to make is referring to COVID as an eye-opener, how closely we are actually linked with our domestic issues. So while we are geographically wide apart, I think now everybody saw that actually epidemically spoken, we are one epidemic space, and maybe we should even consider us as one health space with interlinked and similar agendas. And the idea of this, the main idea of this trilateral agreement is actually to learn from each other how we are addressing those domestic issues. Over the last couple of years, our regional director, Hans, was a couple of times in the US for meetings with HSS and with PAO, of course, with the National Security Council, with Dr. Fauci. And in all of these conversations, the role of science and research and the need to fight misinformation and to build trust that you've talked about showed how connected actually the real issues are that we are seeing on both sides of the Atlantic. But looking forward and beyond also the discussion on epidemic preparedness, there is an issue that we believe that is indeed also mentioned often as the mother of all crises, that is climate change. And that is an important issue for both sides of the Atlantic, and we are actually right now in conversations with both of your teams to see whether we should organize a high-level dialogue on climate change and health as one of the flagship initiatives of the trilateral collaboration. But the list is actually quite long. You've also mentioned many other issues. If you look carefully, if there would be one issue to mention, from my perspective, it would be certainly migration, which is not only a hot political topic, but also a significant public health issue on both sides. And again, there we've already started to identify some specific opportunities for collaboration, including a dialogue on migration and detention that is upcoming in Portugal next month, and in which you, I think, both will, your teams will also participate. But more broadly, equity, inequitable access, vulnerabilities have been referred to, and one of the more recent discussions has been around specifically the health of indigenous populations as standing out as well, and particular in the Arctic region, which is a region that is actually also a shared geographic space between Europe and the Atlantic. So the others, cancer maybe also is one of the defining issues, and we've got close collaboration between the US Cancer Moonshot and the European Beating Cancer Plan. So these are the second point, the domestic issues that are connecting us, and which we certainly can develop further to overcome also this unidirectionality of collaboration. So the third issue I briefly want to mention is how we can work together to shape the global health agenda. And here I'm not just thinking about the current ongoing discussions about the pandemic Treat Me, the pandemic fund, the IHR revisions, but maybe rather thinking more broadly about one of the chief COVID lessons, which was that we always say health is not everything, but without health there's nothing. Mm-hmm. So really this idea that there's a broader agenda that we want and we can push, which is putting health at the center of social and economic development. And that was labeled by the famous Monti Commission as the economy of well-being. And I think there certainly is an enormous difference that we can make if we join forces to push for this vision. You've mentioned G7 and G20. Again, we've seen health having a more prominent place in those discussions, definitely. Recently, we had the joint meeting of Ministers of Finance and Ministers of Health in India, which was quite a milestone. But we also see that this place that health got around this table needs to be defended, especially in the post-pandemic era. And I think this is where we can really join forces. And of course, we are excited to see Brazil taking over the G20 presidency in, I think, 7 weeks from now, and happy to work on this. There's also regions, not globally, but in the European, one region, the Central Asia, which I think is a region where we have also got very aligned priorities, both from the European side, but also from the US side. Just a few weeks ago, our regional director attended a meeting of the 5 presidents of the Central Asian countries and launched a roadmap for health and well-being that WHO facilitates.
the result of research teams and partners working across North America and in the European Union, together with partners from across the globe. For instance, our transformational drug for multi-drug resistance tuberculosis, bedaquiline, as well as our Ebola vaccine. Transatlantic collaborations have been at the heart of major public health success stories, and they will continue to be so as we evolve to best serve global communities. I'd like to highlight today 3 critical learnings and possibly practical, actionable opportunities for greater transatlantic collaboration to enhance our preparedness and response. First, alignment around pathogens that pose the most risk and agreement about funding for R&D. We've talked about climate change. We know that this is just a matter of time. So how can we actually plan better ahead of time? Second, the importance of public-private partnerships, which have been pivotal in the response of the current pandemic, but not only. You know, in the last 30 years, they have been there every single time that we've had a crisis. And third, regulatory collaboration. So, taking the first point, major funders, the WHO, are working on defining infectious disease priority pathogens. An agreed upon priority pathogen list is essential to being prepared for the next pandemic. Taking it one step further, I would like to see the NIH, BARDA, the European Union, HERA, the newly formed agency, coordinating not only on the priority list, but also how funding would be allocated to enable the most efficient and effective discovery, research, and development. We all know that dedicated funding is needed to bring multiple compounds forward for all priority pathogens, let's say 3 across the top 10 pathogens. So we have multiple shots on goal, no matter what is coming into our direction. And we do believe that public-private partnerships like those who flourished during the COVID-19 pandemic are actually critical to success. So for COVID-19, important efforts like the Innovative Medicine Initiative Care Consortium, so this is therapeutic interventions for coronaviruses that was sponsored by the European Commission, or the NIH Active collaboration, basically a partnership to develop a coordinated research strategy for prioritizing and then developing most promising treatments and vaccines, have really speed up that particular process. Both these efforts were used to find and respond and prepare these interventions are public-private partnerships and are noteworthy examples of the power of PPP in moving purposely, but also nimbly. For instance, in Active, we were able in 2.5 years to review something like 850 compounds and launch 37 clinical trials. Yeah, even if some of them gave negative results, those were as important as the positive ones because they can be used to actually address some of the misinformation in the public. More importantly, between these public-private partnerships and the Intrepid Alliance, which is a private alliance, so companies coming together to address this issue, we can progress together to address the next pandemic. A recent forecast, and I don't want to be gloom and doom, but a very recent forecast by Airfinity put the risk of another COVID-19-like pandemic to 27.5% by 2033. So in the next 10 years, we have about a 30% chance to see again something like that happening. We cannot enter into this next pandemic as unprepared as we were. And then finally, regulatory innovation to incorporate phase 3 clinical trials, human challenge studies, comprehensive preclinical data, to push for approvals or conditional approvals, and to speed the time to amassing the evidence needed for full regulatory packages. We have seen that worked very, very well in the last pandemic with this extraordinary degree of collaboration between industry and national and regional regulatory authorities with the WHO. Everyone actually looking forward to bring this intervention as fast as possible ahead. And for these products, early guidance, rolling reviews by the FDA, by the EMA, by the WHO, and the central coordinating role of the International Coalition of Medicine Regulatory Authorities helped align the industry to actually bring these interventions forward. Not only that, but really avoid duplicative clinical trials, things that would be, maybe wasting time and money. So I'll stop here and look forward for the other panel members and to questions from you, Adnan, and the colleagues in the room.
Thank you very much, Dr. Ruxandra, and thank you for talking about these issues of most risk pathogens and this notion of an essential list, the power of public-private partnerships, and of course, regulatory collaboration. I think all three very important, significant issues. So thank you for being so patient. We've nearly been an hour now, and you've heard very important reflections from my colleagues on the panel, and it is time to engage you in these discussions. And so I'm going to request for comments, reflections, or questions from the audience, and then go around and see. And if you don't have any, I have plenty. So I can keep my five colleagues here very busy with some questions that are hitting me as I heard. And I hope some of you also heard there's a thematic basis, interestingly enough, as we moved across our colleagues here from this side of the table to there. But does anybody else have a reflection or comment or a question to any one of our panelists? And what I'll do is I'd like to collect 2 or 3. And this is my usual rule when I moderate. Your question and comment should be deliverable in 1 minute. You are not a panelist, unfortunately. So I can't give you 10 minutes to ask your question or to make your speech. So you have a minute to give your point, your burning question, and I'll try and get as many people as I can into the discussion. Yes, sir.
Or should I just yell?
No, there's a microphone coming.
So 10 minutes in 1 minute. Bo Elias, I'm from Copenhagen Institute for Future Studies. Really appreciate all of these things. I also work both in Europe and in Latin America quite a lot. One single question. What is the thing we start with? We have had a lot of talks over a lot of decades. Where do we start?
Excellent question.
Together.
Yeah, excellent question and short, which I love. Very important. Now I have the young lady there. Yes, right there.
Thank you so much, Karin Sipido, KU Leuven. I've worked with the European Commission, Dr. Oksana Dariel knows that. My question is directed to you and to everyone, and is very much in line with what was just said. If we have to priorities, and I agree, there has to be priorities, who's going to set a priority and how? Who will be around the table? What will be the mechanisms? What will be the drivers to decide on priorities, especially in research and innovation? Because it's not only about implementation, it's also having the pipeline ready for the innovation to be implemented.
Deep question, actually. It's a very deep question about who, how, what, if we start prioritizing. Yes. Next is in the same row, right in the middle. Yes.
Thank you so much, Nabiha Kazi with PAI. And my question has to do with money and leveling the playing field. We know that, and very thankful, Lois, of course, I say this with so much love and appreciation for the US government, but the US government and the Gates Foundation are 2 of the biggest funders in the global health architecture, 2 of the biggest funders of the World Health Organization. And we often know that those who foot the bill also advance the agenda. So my question is, how are we going to level that playing field in terms of who exerts influence to shape that global agenda and expand the tent of influence?
Excellent. You know, this crowd is very well informed. They're really they're really pushing us. I'm going to take one more, and then I will ask any panelist to respond. I'm sorry, I missed that. Yes, that gentleman right there. I saw his hand, and then I'll do a second round. So keep those questions coming. Yes, sir.
Thank you. Casimiro Vizzini from the One Sustainable Health for All Foundation. I've heard a lot about One Health, mentioning the link between health and climate change. And this year, the COP28 will be will have for the first time Health Day. How do you think we can structure and change from just an intellectual approach on One Health to a practical approach?
Thank you very much. We've sort of gone beyond transatlantic health, but that's okay. We will address this, because I think the point has been made that it's not just transatlantic, but it's more than that. So what I'm going to do is I'm going to allow everyone to reflect on any of the questions you can pick up, starting with you, Dr. Barbosa, and making my way down the panel. If you can take 2 or 3 minutes each to reflect.
Okay, so thank you for the questions. I will leave the funding part for my colleague Lois. But let me tell you that we have very specific topics. For instance, with European Union, our priority now is how to strengthen regional production in Latin America and the Caribbean. So this is clearly, of course, it's a complex of, we need to strengthen regulatory capacity in the regions. We need to use the revolving funds that we have to leverage the products that we already have in Latin America and the Caribbean. So with a very strategic investment, we can qualify these productions to be pre-qualified by WTO. We can scale up the production, and we can probably be much less vulnerable in the case of a new pandemic that will happen. Hopefully not in 2033, but we don't know when, but will happen. With this trilateral agreement, we are working together, Euro, PAHO, and the United States government, to identify 3 topics, because both think that we have this pragmatic view. Let's not start with a long list of 13 or 14 priorities. So we are picking 3 things that are common in the region: refugees and migrants, digital transformation, inequities, because we both have these dimensions to start working together. So these are my comments for these very, very important questions that you have made.
Thank you very much, Dr. Barbosa. Lois?
Thank you, Professor Heidner, and thank you very much, friend, Dr. Jarvis, for giving me the easy question. So let's see, where shall I begin? You know, the couple of questions we got on prioritization might come off as surprising, my response, but we obviously have an opportunity to focus on those things that feel safer, you know, like I think people are tired of the expression low-hanging fruit. But whatever, however you pick your fruit, there's an opportunity to just say, okay, well, this is manageable despite, you know, we have available resources, we have political will, let's just do the R&D we're used to doing. I think our approach in this government is to lean into the hard, and you're hearing from Jarvis and myself, you know, the importance of not shying away from that which is critical and frankly, like, what's in crisis. And I think for us, that is absolutely the climate crisis, and acknowledging that if we just continue to say that's too hard, that it's not going to go away. I think similarly for us, that is in fact sexual and reproductive health and rights, and it includes how we advance priorities and programs for LGBTQI plus communities. And then I think, again, as Jarvis has mentioned, as has Good Day, this issue of migration and health as it relates to conflict or other crises such as climate crises, whether, you know, and so this is why we are coming together and saying, okay, these problems are just, they're out of hand, frankly, right? And there's no way that we can wrap our arms around them as health or other development professionals unless we truly join forces and come together to resolve them. So that those hardest things remain priority for us, frankly. really quickly on funding, Nabiha, again, thank you for that question. There are ways that the U.S. is trying to shape the evolution of the funding landscape, and I want to include others in this as well. There are really important conversations underway that acknowledge the success of the global health architecture to date, and also voice a commitment to address its shortcomings. The system of today cannot be the system for tomorrow. And we knew that even pre-COVID, but we know it especially now. And so I think that is partly why you even see initiatives like the Pandemic Fund be structured a bit differently. Now, there are plenty of arguments saying it's, sort of usual suspects, usual business. But I think that there are other folks who see, well, okay, there's a way that LMICs are at the table to begin with, driving the priorities, if not the parameters of those priorities. And then we see with the initial rollout where that money is really going, and it's going to work. It's not going to Geneva Giants, right? Like, it's going to people on the ground and in the field who are facing on the front lines these issues, these crises that I just highlighted head on. So hopefully that is a signal or sign of what could be done, but completely accept that this is an open question that we need to answer sooner rather than later.
Thank you so much.
Thank you. Yes. Let me also add a word on the issue of the funding, and we definitely appreciate, of course, the very important contributions from the US and from the Gates Foundation, and mostly no strings attached to those. But indeed, there has been a profound discussion between member states about the ownership of WHO and leveling the playing field. And one of the very important commitments that was made at the last World Health Assembly was for member states to increase the share of the flexible contribution, the assessed contributions, we call them, to the organization. So currently, of the budget of the World Health Organization, only 20% are coming from the membership fees that countries are paying, and the rest is monies that we are raising ourselves, and indeed many of them are then also linked to specific projects and purposes. Now, member states across the board have agreed to raise the share of flexible funding from 20% to 50%. So half of our budget at the end of this decade will be from flexible resources, and that definitely will change a lot for us. It will enable us to cover much better the core of our mandate and gain and preserve our independence, and it will definitely also change how member states look as an organization in terms of the ownership of the organization when they are across the board contributing and ensuring the core of our operations. Then on the other question on the where do we start? Yeah, indeed, this is a super difficult question, as always, with prioritization, and we had that discussion with our colleagues from HHS and PAHO with regard to getting now this wonderful agreement implemented. And indeed, I definitely agree with you. Nobody wanted to shy away from the tough issues, and I think all the issues on our list are the hard ones. So we definitely felt it's not just going for low-hanging fruits or having some quick wins. But I think at the same time, I think as always with getting things started, it's important to show in practice that things are moving and to model collaboration. Even if none of the issues will be resolved, I think it is important that we do show in practice how collaboration can work. And that can be best done if we have a few issues where we get started, but I think nobody would like to limit our collaboration through this prioritization, because as soon as we go beyond the 3 priority issues, there's so many other opportunities for collaboration. This is why we are trying to, at the same time, pursue a bit of a mainstreaming approach and talking, at least in our office, and encouraging all colleagues to think in a transatlantic way and to start identifying more and more opportunities. So to really instill a culture of collaboration.
Thank you so much. Elaine?
Yes, well, some answer to where do we start? And I'm setting aside, when there are emergencies like, COVID, where obviously what we need are excellent communication canals, with all the different partners possible. But where do we start? And what came to my mind was, yes, we need to think globally, but action, we have to act locally, as we know this say. And to act locally, it comes to listening and figuring out what our people's need. And here comes in social accountability and all the partners. And if we can encourage people in their different settings to identify what is or are the main how they can tackle one aspect of the consequences of climate change and work together in order to have quickly some changes and be encouraged. I want to cite my now colleague Sofia Zungas from Monash. She mentioned frugal innovation yesterday, and I thought that was wonderful, because many innovations or implementing changes do not always need very large amount of money. So not to be discouraged, we have to try and act locally, in my view.
Thank you so much. Alexandra.
To start with, I do believe that all these problems have to be tackled through partnerships which are based on trust, on collaboration, and where each and every one of the partners is focused on the area that they can put forward, they can deliver, and then work within the ecosystem with all these other partners. The COVID-19 pandemic, well, it is a very specific episode, taught us that this is in fact possible, and we can move from the paradigm of panic and neglect, as Dr. Tedros is mentioning, to something where we can actually deliver very fast. Where there is a will, there is a way. So, for instance, during that time, public and private entities came together. They forgot their barriers. They actually put all their intellectual might all together in order to find the solutions. They looked into their drawers in research that started 25 or 30 years ago. Everyone says, those mRNA vaccines, how did they were developed so fast? They were developed so fast because 25 years of research for oncology or for other applications was actually put to work into these circumstances. There have been, for instance, in the context of the NIH, the active network, things that have been tried for many years, but because there was that pressure, we were able to deliver. So, for instance, we do have clinical trial networks now in the United States. Some of them are international, the same with the Solidarity networks or the Recover in the UK, where the clinical trial sites came together to work together and deliver much faster. Can we actually conserve those learnings that we were actually really able to deliver during COVID-19 and not re-engineer and put them to good use? We know that because climate change is there, we will have other pandemics. Yeah, we do have an acute, many other problems, being mental health, being, cardiovascular, name it. Can we use what we have learned from this pandemic and actually be better prepared and tackle some of what we have thought are entrenched issues in global health?
Thank you so much. These are amazing reflections and critically important. Before I cool down the temperature, I like to up the temperature. So the issue here is that there are neglected tropical diseases that have been killing thousands and thousands of people in the South. But there was no cooperation, there was no funding facility to solve them immediately. In my country, the United States, the drug problem affected African American and Latino and brown and black populations for years. But suddenly it started affecting the white population, and voila, there was tons of money now suddenly available. I'm not making a political statement. I'm an academic. I can actually make a political statement without feeling bad about it. But I'm making a factual public health statement here. So it does matter who is affected. It does matter who takes those decisions.
Yeah.
So these are uncomfortable conversations, but we have to have them, and which is what I thought a couple of the questions were really hitting at. Were really hitting at he or she or whom is at the table then decides for the rest. And how do we structurally change that? And that's part of this conversation that needs to happen. So before I go back to my panelists for reflection, I'm going to take a couple of burning questions. These have to be really burning ones. And then I will go back and ask them for final closing thoughts as well as to react on my... Yes, sir, you had your hand up very quickly.
Thank you very much.
Remember, short, 60 seconds. Yes.
Okay, my name is Aras. I'm president of Kurdistan Health Summit. I'm looking for a partnership, a new partnership. So I think between Roxandra, Lois, and you, Adnan. So,
Yay! Do we get a prize?
of course, with Kurdistan Health Summit. So we have a very good base and great team for researchers in Kurdistan Health Summit, focusing on Iraq, Iran, Turkey, and Syria. And because you said we have one health space and one pandemic space, I think we will be a good partner if we all four parties come together and we will do the research and you support us. So you support us and fund us. Thank you.
Bold, I love it. Bold and brave. Yes, sir. Right there.
Hi, great panel. My question is really picking up on what, Professor, on your comment. It's about equity. And what are the transatlantic lessons for global health equity? It's a simple ask. It's a big thing now. Because I think we focus so much on partnerships, so much on what we can do to unleash technology, but the same people are being left behind. All of these partnerships, when delivered, do not reach those who need it most. So what are we going to really do about equity?
Critical outcome of all of these collaborations. I think I have only time for two. I spotted the young lady in front, and now the question is the last one. I'll see who can raise their hands. Yes.
Thank you. My name is Christine Sørensen. I'm president of International Health Literacy Association. And we saw with COVID-19 that health literacy really matters. And how can we now bring in also the public and also redesign our systems to actually meet the needs, like Dr. Hyder just mentioned. Health literacy is big business, and it's a political choice. So I would love to hear about your ambitions in this regard.
And you know, in my city of Baltimore, my wife is a cardiologist. She'll tell me that there are serious concerns she has when somebody from Baltimore City comes to see her. The assumption that you're sitting in a high-income context does not mean the assumption of health literacy exists. So it's very important. The furthest hand I see is the young lady back there. And I'm going to give her the last question before I go round. Yes, please.
Hello, everyone. My name is Mona Mude. I'm originally from Somalia, but I come from Nashville, Tennessee, USA. And my question is that there's a lot of civil society organizations, especially global health nonprofits, that are doing a lot of work around global health, especially in developing countries. And there's also a lot of people that are from the diaspora communities actually know a lot about what is happening back home in the native countries and so forth. But many times you feel like a lot of global health, especially small global health nonprofits, are overlooked when it comes to funding. They usually depend on like private funders or foundations or individual giving and so forth. How can we improve funding for those type of organizations and also engage diaspora voices that are that have first-hand experiences of some of the challenges we're trying to address at the global level?
Thank you. Amazing. From Somalia to Tennessee, you've covered the whole world. So thank you for being the last question there. So dear colleagues, we have questions around the outcome of these collaborative partnerships. Will we affect equity, yes or no? What are the roles of the community and health literacy? And very importantly, are we going to engage civil society in these partnerships and collaboration? And I will acknowledge that we don't have a representative on the table here, although sometimes academics are considered non-governmental civil society, but we have our own brand, and so we are missing. This time I'm going to start with Dr. Roxandra and move this way, if you can have a couple of minutes of reflections on any one of those questions.
Yes, thank you. And I'm attracted by giving examples. So I will give an example of our TB drug bedaquiline. In order to ensure access to this life-saving new drug in new regimens for tuberculosis, we actually partner with Stop TB Partnership, which is the largest procurer of TB medicines, yeah? And they actually, together with us, helped bring those medicines to those that really need them the most, working with the communities, and obviously this collective investment, and it is really critical in order to foster the access to life-saving interventions. I would also like to say that throughout all our work, we have really engaged with healthcare workers. Be it in the communities in sub-Saharan Africa, be it, for instance, at the implementation of our Ebola vaccine, and be it in the United States or in the high-income countries that you were mentioning, in these communities that are not all served in the same manner. And we do believe that investing in healthcare workers, continuing this investment, would actually be an essential component of access.
Thank you very much. Elaine?
Yeah, well, on the transatlantic lessons regarding equity, which was one question asked, one action is related to accreditation of professionals, and there is an effort currently for instance, in North America, we share the same accreditation system, but in the Francophonie, with Africa and Asia, Europe, there is a program to bring up, medical and health professional education, and the criteria of social accountability has been added in the US and Canada, and now, with the world, there is another association, for other countries. And if social accountability, if for accreditation, you need to demonstrate not only that you are teaching, but that in, the different clinics, institutes, there is a social accountability approach. It is likely that equal protection, for the diversity of populations that are, treated in that area will improve. So one potential action is through accreditation of professionals.
Thank you, Elaine. Gundo?
Yes. So, wow, these are really big questions. On the issue of equity, let me maybe just say a word about equity, not only within countries, but also in between countries. And in Europe, it's, of course, an immensely diverse region. And we, for a long time, have seen the situation where there was part of the region who was deemed to have big problems, and they will need expertise and financial support from the other part of the region, which was supposed to have figured it out and have very nice health systems. So I think for long there was some kind of a rhetoric around, well, we should overcome that dichotomy, but it took until COVID that people really felt that actually some of the countries that were supposed to be in need of help performed fairly well, and some of the countries that were supposed to have figured it all out suddenly realized that there are big issues. So actually what we are trying in terms of the address already this bigger inequity and inequality between countries, and try to organize a new way of working together within the region, where indeed we overcome this dichotomy of giving and taking, and where we're trying to install new ways of dialoguing. And we do see actually a lot of movement. We have a lot of countries in the EU now who are interested actually to talk a lot more and learn a lot more from countries that they formerly supported unidirectionally. And we've got opened recently a country office in Cyprus, which is a new one. We've got now requests for collaboration also for the benefit of the country from Germany, from France, from Portugal. So all countries that previously were not actively banging on our door. So there's a bigger issue of equity, and I think that is interesting because with our Transatlantic partnership, we can also model a new way of dialogue. I've talked about the traditional way. The traditional way was the US is supporting European countries in the East. But now I think we are talking about something different. And we can model that new type of collaboration. I think there's then, of course, also the equities within countries, of course, and there we can share experience. And Euro has a lot of tradition there in many areas where we bring in civil society, thinking about HIV. I mean, that we've seen in different countries, but we've seen countries in Europe where civil society is actually being a recipient of PEPFAR grants or Global Fund grants, has taken over organizing care for HIV, particularly for drug users. It's this kind of a self-organized movement, which I think there are lots of lessons to learn and to share. But at the end, I think addressing equity at the end boils probably down to a political choice. As we say, it's a health as a political choice. And I think that's where also, apart from the technical, the political element is very important, that if we join forces in calling for that, it's sometimes complementary to what we can do in any single country alone from within.
Okay.
Thanks.
Thank you, Gundo. Lois?
Well, first I want to appreciate the invitation to Kyrgyzstan Health Summit. I believe I received an invitation last year too, so you are persistent, which I'm grateful for. I also want to acknowledge the comment on diaspora communities. The U.S. launched not quite a year ago, but on the heels of our Africa Summit, a new council on the African diaspora. I'm not getting the name right, with apologies, but it's essentially and it's recently been announced the members of that council. So it's quite still quite fresh, and the goal is to pull in these perspectives, and I think importantly, really recognize that that the diaspora in the U.S. and frankly probably in many of our countries has much more to offer than we have been able to tap. I mean, the work has been happening through the diaspora for years, whether with regards to financing, service delivery, and everything in between in this space. And so I just wanted to thank my fellow Tennessean, my families from Tennessee, for offering that question or comment. I do want to focus on the equity question that was posed, because that's something that had been sitting with me while we were here, and I was hoping someone would get to it, so thank you, sir. And I want to draw from the comments just made about how we actually can and do push each other across the Atlantic on this issue. So look, I mean, it was the Europeans who really pushed for this pandemic accord. Let's give credit where it's due, and recognize that, you know, I'm not telling any secrets here. You know, there was a lot of pressure on countries like the U.S. to get on board with this plan, and we did, and we have, right? We have a whole pandemic team, a negotiating team to see this through. And frankly, this is how I think we are potentially applying pressure in our own right, by saying, all right, we're at the table, let's do this. And let's do this in a way that makes sense for the world and ensures that we never repeat what happened again. There were some fine and even good things that happened in COVID, like innovations, right? But there were some challenges to accessing those innovations, which I don't have to retell today. And so what I do want to acknowledge that countries like the US, countries in the European Union, and countries elsewhere in the Americas are doing is we are talking concretely about how to correct for those mistakes in these negotiations, right? And so whether we're looking at what is included in contracts in ways that we can deliver these types of products more rapidly in the future, either directly from manufacturers or from countries that are able to procure them, is an open question, right? But it's an open discussion. There's obviously a conversation about tech transfer, and I'll say as a U.S. government, I think people saw that we worked with the Medicines Patents Pool to share the technology that our NIH owned. That was on purpose, right? We could have not done that. We could have said, oh, well, people have the meds they need, so, you know, what does it matter? But that step, we understand, was important, if only to set or sustain precedent with regards to government-owned technologies and those being voluntarily shared. And then obviously we've almost been competing on how we invest in manufacturing hubs, right? So there's sort of the short, medium, and longer term solution, and I would put those types of investments into that bucket in some cases, but we know that the answer can't always come from the north to the south, right, top down. We know that ultimately countries like South Africa, obviously India, Brazil, and elsewhere, really countries, of course, throughout other parts of the world, really are poised to provide for themselves, and they want to be able to provide for themselves. And so the degree to which we can also work transatlantically to support those efforts is going to be really important.
Thank you so much, Ms. Pace. Dr. Barbosa?
No, thank you. I fully agree with Lois about this, how we can ensure, and this will be a very important discussion for this year, next year, because this will be approved on the World Health Assembly 2024, how we can establish a global mechanism that can really guarantee equitable access when we have a pandemic. So I fully agree. So I will move talking about the equity, but also because we are the most unequal region in the world. We have member states like Canada and the US, but we also have Haiti and Guatemala. But also within the countries, we have a lot of inequalities, mainly indigenous population, the poor families that live in the big slums in every big city in Latin America, Afro-descendant population. So this, and this really matters for health. This was one of the main important reasons that Latin America was the epicenter of the pandemic. And before the vaccines were available, countries that have 50% of their population in the informal economy, that don't have a social protection network, they could not implement effective policies, non-pharmaceutical policies. This was the reality, and this called the attention that countries in Latin America and the Caribbean, they need to receive more support. One thing. Second, I fully agree that if we don't take into account the inequalities that we have, no public policy, public health policy will succeed. Because if we don't identify what are the barriers, and some of them are cultural barriers, are social barriers, and to develop a strategy to overcome them, we are always leaving some group populations behind. And nowadays, we are not only talking about the neglect tropical disease, because in general we associate poverty with neglect tropical disease, but it's not. They are most vulnerable for neglect tropical diseases, for non-communicable diseases. The prevalence of smoking in countries in Latin America among the poorest quintiles of the population are the double of the richest. Obesity is increasing among the poorest families too. And so we are talking about, for climate change, they are the most vulnerable population when we have a extreme weather problem in a region, a hurricane or a storm or whatever. So I think that it's very important to take this into account and to give the contribution, because the health sector needs to be part of the process to break this vicious circle between poverty and disease and health. So I think that this is a very important contribution that the health sector can provide.
Thank you so much, Dr. Barbosa. So all good things must come to an end, and so this session shall too in the next minute. We began this session by saying that, yes, transatlantic cooperation is a good thing for health, but it must be bidirectional. There must be learning and innovation going on both sides. And then you said, look, why just transatlantic? Why not global? And the panel seems to say, yes, the spirit is there. Let's build these lessons not just for transatlantic cooperation, but for bringing in other continents in as well. And fundamentally, I think we've raised today great concerns around equity, which are concerns that are really, really important. And I think the assumption that a particular sector does not value equity should also be tested. Because government officials and intergovernmental organizations and academics and private sector actually seem to be saying to me, they're concerned about equity, but maybe they don't have all the solutions. So the onus for getting that conversation going and for holding all of us in a compact of social accountability as you said, Elaine, is that each one of you is also responsible for this, that each one of you has a role. And if you believe that they should do something which you will value, then you need to be agents of change as well. So with that, I welcome you to become agents of change and take forward this transatlantic cooperation. Join me in thanking all our panelists for today.